Acute pyelonephritis. So what is acute pyelonephritis? Manifests with fever, chills, back pain, nausea, vomiting, tenderness in the coastal vertebral area, in most cases with acute pyelonephritis being treated in the ambulatory setting. So this is where you tap on the back, and if the patient jumps off the bed, you know for sure that's going to be a positive. It's a clinical diagnosis. You can also see this on imaging, but can be a clinical diagnosis. Acute pyelonephritis is a bacterial infection of the renal parenchyma and collecting system, most commonly caused by ascending uropathogens, so coming upward from the urinary tract system, characterized by fever greater than 38 degrees Celsius, flank pain, coastal vertebral angle tenderness, as we discussed, and laboratory evidence of a urinary tract infection. Empiric antibiotics with PO-fluoroquinolones are recommended. Uncomplicated, can get ciprofloxacin or levofloxacin for 5 to 7 days. Remember, these do have side effects. They're great medications, but have side effects. In areas where fluoroquinolone resistance are higher, greater than 10%, is initial dose of ceftriaxone 1 gram or consolidated 24-hour dose of aminoglycosides can be prior to quinolone therapy. All right, let's go back. Ceftriaxone, probably some systems are going to ask you to go to ceftriaxone over the fluoroquinolones due to the side effects. Aminoglycosides, they're very good, work very strong, but the side effects is what we have to be worried about. Here you may, if you're not used to prescribing these, this is where you may want to get help from your pharmacist. Hospitalization is indicated for those with hemodynamic instability, unable to take PO medications. Pregnancy is very important. Remember, in pregnancy, we need to treat these urinary tract infections. We need to treat them quickly, and we need to make sure there's good follow-up. Patients with kidney stones, because in their urinary tract, they're going to have a stone. The stone, even if it's not obstructive, there can be an area or pockets. Just think about it. You're not going to have your clean tubes, and you have an area where infection can occur. You can have obstruction. If there's obstruction, the obstruction needs to be removed by your urologist, so that way you can have free-flowing urine. Urine backed up has a great risk for infection. CT is preferred, or ultrasound if pregnant, for symptoms lasting greater than 72 hours to rule out perinephritic or interrenal abscesses. If you have one of these abscesses, usually you're going to have to call IR and have them drained. Very important. Remember, and all these things we talk about in this infectious disease, if we do not see improvement within 48 to 72 hours, we either have the wrong diagnosis, or we have the wrong medication for treatment, or we have just everything else is wrong and we're missing something big. This is where we have to make adjustments as a provider and go, something's not going well, and we need to get feedback from our patients, but also we need to follow our patients to make sure that we make adjustments. Urological evaluation emergently in those with a stone or obstructive symptoms. Urologists will jump if you see the thing called hydronephrosis, meaning that there's the kidneys have become enlarged, because remember, the urine has to flow through freely. If it becomes backed up, just think of the kidneys as kind of a capsule. When that capsule gets enlarged, that's because there's an obstruction. So you're looking for an obstruction. The urologist wants to remove the obstruction. If there's hydronephrosis without signs of obstruction, it's quite possible that the patient has recently passed a kidney stone and the hydronephrosis has not resolved. Acute pyelonephrosis, the continued discussion. Complicated infection should be treated for 14 days. IV fluoroquinolones, with the exception of moxifloxacin, plus an aminoglycoside, plus or minus ampicillin, extended spectrum cephalosporin, or extended spectrum penicillin, plus or minus aminoglycosides, or carbapenem can be used. Ampicillin plus gentamicin if enterococcus is suspected. This would be gram-positive in the urine. Patients with complicated infections use piperacillin tazobactam. See, we're going to higher level because we're concerned these patients are going to get worse. Tricarbonate, ticocillin, clavulanic acid, cefalpine, meropenem or imipenem. Remember, cefalpine, what could be the side effects? Non-convulsive, status epilepticus. You can meropenem and imipenem can what? They can lower seizure threshold. Piperacillin tazobactam can cause what other side effects can have? You have to look at this side effects such as penicillins. They may have a reaction such as a penicillin reaction. In pregnancy, ceftriaxone can be considered, ampicillin plus gentamicin if gram-positive in the urine. Now, remember, if you give aminoglycosides, such as gentamicin, you need to make sure that you do not have a diuretic, a loop diuretic, because what can happen, you can have an interaction between those, and you can have loss of your, you can have loss of hearing. It's a big deal. IV to PO treatment, IV cephalosporins should be avoided. Use piperacillin tazobactam or fluocinolones when possible. All right, now we'll talk about catheter-related infections. Do not need to do routine UA and culture. This becomes a big thing in the hospital systems. In some hospital systems, the bigger groups, they won't allow you to do a UA when a patient has had a catheter for 24 to 48 hours. Then what they'll do is they'll say is, provider, how about we remove that catheter and you can test 24 to 48 hours after the catheter has been removed. Is this good medicine? It is what it is. The reason why is when you have a catheter-related infection in your facility, this goes up, and you can look it up. It's Medicare.gov. Go to the compare section, and it's going to rate your hospital, the safety of your hospital or your system, based on the fact is how many catheter-related infections you can have. So do the hospitals take shortcuts or do things that maybe we may not think is as scrupulous? Yes, but this is the system we live in. Are you going to get urinary tract infections with catheter-related infections? Yes, you are. You're trying to avoid them as much as possible, but these are things we have to live with. So the statement is you don't want to do routine UAs on these because you will get positives, and it may not be where it's actually affecting the patient. No need to treat asymptomatic bacteria. Treatment of asymptomatic bacteria only in pregnant and those who are undergoing urological procedures, as we discussed before, neutropenic patients, renal transplantation patients, or patients who have urinary obstruction. Culture urine and blood if patient becomes symptomatic. Maintaining the urine collecting bag below the level of the bladder is the best way to prevent catheter-related urinary infections. Recurrent UTI in women. UTI's recurrence is when a patient has at least 3 episodes in the past 12 months or 2 in the last 6 months that can be due to relapse of the same infection or new infection. Excuse me. Relapse infection of the same strain as the initial UTI, but within 2 weeks of completing the initial therapy. Reinfection if there's a new strain or if sterile urine was documented between the episodes. For relapse, the best treatment is the same antibiotic for longer periods of time, 7 to 10 days is reasonable. Excuse me. Recurrent UTIs continue. Prevention includes alternative method of contraception, including using condoms and lower dose prophylaxis daily or every other day, nitrofurantoin or trimethoprim sulfametazole given at bedtime. Does not alter the long-term risk for recurrence after prophylaxis is discontinued. Can also take a single dose medication after sex for prophylaxis is clearly related to sex per patient history. Some cranberry products decrease frequency of UTI by about 1/3, but less effective in comparison to low-dose antimicrobial prophylaxis. The cranberry literature has not really played out. We love for cranberry products to work. The theory is it's supposed to make the urethral surfaces more slick and to allow us to the urine to move out more freely. The literature has just not made that happen. It just hasn't come true. Urological evaluation is indicated if the structure or physiologically abnormality is suspected or multiple relapses of the same strain when the kidney stones are suspected. So if there's suspicion of maybe kidney stones that are causing, remember the kidney stones, so you have your urethra right here or your ureters. And if there's a stone in there, bacteria can collect on that stone. Or if they have some sort of stricture in that tract, that's going to make it areas where the urine is not going to flow freely, bacteria can accumulate. These are things where we need to get evaluation and possibly urology evaluation to figure out why these patients are unfortunately having continued urinary tract infections. All right, now let's talk about acute bacterial prostatitis. It's high risk in diabetics, immunocompromised patients, and cirrhotic patients, and those having unprotected sex and indwelling catheters. It's usually due to ascending urethral infection, so it's coming upwards and into the interprostatic reflex, but it can really be from blood, spread from the blood or lymphatic symptom, lymphatic spread, excuse me. You can have fever, chills, malaise, nausea, vomiting, dysuria, increase in frequency and urgency, and pain in the lower abdomen. The prostate is very tender on examination. Can be the same organization as the UTI, but also gonorrhea can be present. Urine culture and gram stain are indicated along with blood cultures in those who are hospitalized. What's the treatment? Trimethoprim-sulfametazole is an antibiotic of choice. Fluoroquinolones is an alternative. Duration is a long period of time. Therapy is for 4 to 6 weeks. So let's go back and talk about this therapy for a long period of time. Trimethoprim-sulfametazole, we need to do what? We need to follow basic labs such as what? Mainly kidney function, how we're doing. Now with trimethoprim-sulfametazole, you're gonna have a bump in creatinine. This is not caused, it can cause an AKI, but the bump in creatinine is one of the side effects of the medication itself. This doesn't mean it's an AKI, but they can have a hyperkalemia. This can be deadly in certain patients. Fluoroquinolones, we have to worry about what? ESBL. The other things like the tendon rupture, the aortic dissection, but the real big one is, especially in older men, it seems to be his altered mental status. And this can be severe altered mental status where they become extremely delirious, may even need to be hospitalized for that, especially if we're gonna have a long therapy of 4 to 6 weeks. So this is not a set and forget thing. This 4 to 6 weeks of antibiotics, this needs to be followed well. Why do you need so much? Because it takes time to penetrate that prostate tissue. Chronic prostatitis, which is going to be symptoms of recurrent UTI in those with repeat isolation of the same organism from the urine and persistent bacteria. Prostate is not tender and large. It's culture of the urine before and after prostatic massage. Also need to test for chlamydia. Treatment is quinolones for at least for 6 weeks. Trimethoprim-sulfametazole, it can be an alternative. Privomycin is one of the first antibiotics approved by the FDA in the last 20, 30 years for treatment of urinary tract infection. It's been used in Europe for decades. It's very similar to nitrofurantoin and trimethoprim-sulfametazole in kind of the coverage. You can't give it to patients with penicillin allergy or cephalosporin allergy. Cannot be used in patients with inborn errors of metabolism, those with secondary carnitine deficiencies or inability to metabolize carnitine. It's a prodrug of the beta-lactam antibiotic, and it's used for E. coli, Proteus mirabilis, Staphylococcus saprophyus. FDA dosing was recommended 185 milligrams TID for 3 to 7 days. The IDSA had a different dosing where they recommended 400 milligrams daily for 3 to 7 days. Should not be used in patients with acute porphyria. We'll talk about that. Sulfapen extradinosole plus probenecid is another new antibiotic. It's an oral carbamazepine for treatment of uncomplicated urinary tract infections in women. It is an oral prodrug that hydrolyzes by the intestinal esterase into sulfapen, a carbamazepine. Its in vitro activity against fluorocone-resistant ESBL. Oral bioavailability is 40% fasting and 64% with a high-fat meal, so it needs to be given with a high-fat meal. BID, taking BID for 5 days. Not recommended for patients with lower creatinine clearance or on hemodialysis. So people with chronic kidney disease should not take it. Side effects are going to be diarrhea, nausea, vaginal yeast infection, headaches, and vomiting. This is a gentleman, a 62-year-old male, having fever, difficulty hearing, and a hypertensive emergency. In fact, this was a call down from the emergency department, and they said, hey, I want you to admit this patient for a hypertensive emergency. Then you start hearing more is that this patient came in, he's confused, he has trouble hearing, and has an extreme fever. They also said that he had a sinus infection and went to an urgent care and received a steroid pack. So what is our diagnosis? What is our diagnosis? Well, at first hearing this case, it's like hypertensive emergency. They attributed, this patient became more and more confused. They attributed to his pressure as being elevated. And then you start thinking about it, is what does this patient have? So they had a sinus infection, and then they got steroids. So let's think about it. Let's think about meningitis. And this patient ended up having a horrible meningitis. In fact, it was so bad, coming down and going to doing a LP right away, it literally was pus coming out of his spine. Literally, you can see it. So what do you give right away? Is you give the dexamethasone and the antibiotics. We'll discuss the antibiotics that we'll be giving. But this patient came in hypertensive because he had underlying hypertension, but he was in distress, and that's why he had the hypertensive emergency. So that's where we have to avoid being hooked when we get our little clinical vignettes from the ED provider. They're trying to do the best they can, and they're trying to get them into a safer level of care where they can be managed, but sometimes their diagnosis can be wrong, so that's where you have to start thinking as a provider and not just be an automated. Imagine this patient just came in and was not treated at all. He ended up having an extensive course of antibiotics. His hearing, he lost part of his hearing from this, in spite of giving all the right treatments immediately as he possibly could be. All right, let's talk about viral meningitis. The most common cause of aseptic meningitis. So what's aseptic meningitis? It shows negative CSF cultures, but still presenting with nuchal rigidity, headache, and photophobia. Majority is due to enteroviruses, which usually happen in the summer and fall. Can have seasonal infections with various causes. Coxsackie virus can be one. Echovirus, non-polio enteroviruses. Herpes simplex virus can also cause meningitis as well, and those due to primary infection with genital ulcerations. Do not have to have that though, because remember, the HSV lives in our spinal column, lives in there, so it comes out, can come out and show manifestations of lesions, but it can be stuck in there, so you don't have to have lesions. Herpes simplex 2 is the most commonly associated with meningitis. Herpes simplex 1 is more associated with encephalitis. Viral meningitis diagnosis is going to the PCR. CSF PCR for HSV and enteroviruses. Viral cultures are usually not done anymore because of poor sensitivity and very, very long turnaround times. Cannot rule out autoimmune versus medication-induced causes. Serology for Lyme or fungal diseases can be drawn and received. Bacterial meningitis. Now, in this case, remember, is this patient had sinusitis and then they had steroids. So what happened was the provider that gave the steroid pack in the urgent care, were they trying to hurt the patient? No. What happens is the steroids weaken the immune system enough, even made the tissue weak enough where then was able to penetrate and go from the nasopharynx into a distal focus inside the CSF, resulting from dissemination of meningeal pathogens colonizing the nasopharynx or from a distal focus. Let's go back to that again. And let's talk about something. We're going to have a section on the physical exam. We'll have that coming up. And I know that you're taught the Brzezinski and Koenig signs. They're horrible for sensitivity. The reports for Brzezinski sign is the sensitivity is anywhere from 5 to 97%. For Koenig sign, it's 5 to 57%. You know, a head CT should be done before you do an LP. Some things I want you to think about. This is an older attending that gave me this advice, is they said, if the patient is able to sit and watch TV, they don't have meningitis. Well, just think about it. If you're sitting upright and watching TV, first of all, TV will be loud, right? And you can hear, so if you have meningitis, you have inflammation of the meninges, and noise is going to hurt you. You're not going to be able to, light is going to bother you. So you're able to enjoy or watch this TV show, and you're able to see light, and you're able to hear the noise without having pain. So these are things I want you to think about as probably being more sensitive than the Koenig sign. So if somebody out there wants to do the TV sign, and maybe they become famous instead of using the Brzezinski Koenig sign, they're not great indicators for bacterial meningitis. Now let's talk about CSF itself.